start because already 30 students have joined, 30 delegates have joined. Okay, so without wasting further time, we'll start soon. So can you upload your slides by the time I'll introduce you?
I already checked it, no issues.
Yeah. Can you upload, share your screen?
Is it fine?
Yeah. Okay, great. So your slides are visible. So let's start today's academic meet. So today we are going to have the basic and the advanced knowledge on antibiotics. I welcome you all to this academic platform of Apollo Mumbai Critical Care Learning Network. This is the 28th in series. I am Dr. Gunadhar Padi, the Senior Consultant Critical Care Medicine, Apollo Hospital, Navi Mumbai. And with us, my colleague, Dr. Akhilesh Tandekar and Dr. Swapnil. And today we have our esteemed speaker, Dr. Anup Kumar AS. Dr. Anup Kumar AS is the Senior Consultant and Chief of Critical Care Medicine, Baby Memorial Hospital, Calicut. And he is going to be very instrumental in teaching us the basic knowledge about all the antibiotics, which is going to help us in understanding the concept of antibiotics. And also it will be useful to all the exam goers, the DNB students and the IDCCM students and the fellowship students. So without wasting further time, so let us start today's topic. So it's all yours, Dr. Anup. You can start the lecture. Thank you from my side.
Good evening, friends. First of all, I would like to thank Dr. Gunadhar and team from Apollo Mumbai for giving me this opportunity to participate in this prestigious platform. So today we'll be discussing the basic concepts about antibiotic. Probably maybe in coming sessions we may be able to discuss it in detail, like the MDR organisms, how to choose antibiotics, the case-based discussions, all those things. Today we'll be just giving you an overview about the basic concepts about the antibiotic. So as you all know, without having the basics, you may not be able to learn further or the advanced thing. So don't expect too much in this session. It will be the basic concepts, and over this concept, we will have to build the further knowledge about the antibiotics. So coming to the topic, the proper, we'll be discussing basically the basic concepts and some common infections. We will not go into the details about the infections and the infections-based antibiotic selections. So how we are going to like approach a patient who is requiring an antibiotic. So as you all know, like whenever a patient is coming to the ICU or like to the ward, so we'll be doing a detailed clinical assessment. So based on the clinical assessment, we will be having a working diagnosis. And after that, you will be asking for diagnostic workup. And based on the clinical assessment, diagnostic workup, we will have to make therapeutic decisions. And obviously, we will have to educate the patient also, like what are the things what we are going to do and what is our inference about the clinical assessment and diagnostic workup. Based on that, like we will have to initiate a treatment, and that is the initial evaluation part. But during the subsequent evaluations, like we will have to do the clinical reassessment whether the patient is responding to the treatment what we are already provided, and obviously we will have to do the data review, especially like what is the trend in the patient's status, and obviously like other details also. Other details in the sense like the culture and sensitivity, other the patient parameters like the renal parameters, all those things, and we will have to modify the antimicrobials and obviously the antimicrobial dosages also. So I'll just give you a history about a patient, like a 38-year-old lady who is presenting with 2-day history of fever. She's having left flank pain. She's also having dysuria. Now she is hypotensive, tachycardic. That is why she is shifted to the ICU. So a 2-day history of fever with flank pain, dysuria, hypotension. Now having tachycardia and hypotension, and she's also having bilateral renal angle tenderness on clinical examination. So this is our case. And in the urine analysis, there is numerous vessels, and the specimen was sent for the cultures, mainly the urine, and the blood was sent for the cultures. So, so which empiric antibiotic we are going to choose here? So we have done a clinical assessment. I've already told the patient is having hypertension, tachycardia, and like other the diagnostic workup has shown numerous pustules in the urine, and we have decided to start the patient on antibiotic. So here, based on our the data in our the antibiogram in our hospital, we will have to select. But at this point, you have to always think that this patient is hypotensive. So based on that, we will have to decide which antibiotic we are going to start. So before that, what are the categories where we are going to use the antibiotic? We can use the antibiotic prophylactically to prevent the infection, mainly like the surgical prophylaxis. If you are going to operate a patient, you can give an antibiotic to prevent surgical site infection. Or we can start an empirically the antibiotic, like a patient is coming with a community acute pneumonia. We don't know what is the organism, but with our available data, we can assume that this may be the probable organism and we can start an empiric antibiotic. The same way a patient is coming with a urosepsis without any previous history of antibiotic exposure, no immunocompromised status. So, based on the hospital antibiotic policy or your previous antibiogram, you can decide which antibiotic has to be started without the proper culture and sensitivity report. That is called as an empiric antibiotic therapy. And we have a definitive antibiotic therapy, like where you are getting a like in this case, you are getting a blood culture or like a urine culture, which is showing which organism is growing and what is the sensitivity. So based on that sensitivity, you can escalate or de-escalate the antibiotic. But the definitive antibiotic therapy, like always, will take time because we have to get the culture and sensitivity report, which will take at least 2 to 3 days. Nowadays, we have the genomic methods, all those PCR-based techniques where we can identify the organism immediately and we can get the antimicrobial resistant genes also. Based on that, we can decide which antibiotic to be selected. Those selection, those like advanced part, like how we can select an antibiotic based on our AMR genomic panel, or like what are the phenotypic sensitivity, genotypic sensitivity, etc. We can discuss in the coming sessions. So today we are not going to discuss all those things. So coming to the prophylaxis, like as I would already told, it is basically the surgical site infection, and again you can infective endocarditis prophylaxis, etc. We can give. The empiric is like as I've already told, we don't know which is the organism. We know the clinical situation. Based on the clinical situation, you decide. But in definitive, like as I've already told, based on the culture and sensitivity, you know the organism, you know the sensitivity, and you know the patient clinical status also, whether hypotensive, like tachycardic, or the features of sepsis, septic shock, etc. Based on that, we can select a definitive antibiotic. Here, the culture and sensitivity report is already available. So, what is the optimal antimicrobial agent? So when you are prescribing an antimicrobial agent, you have to consider which drug you are going to choose based on the data which we have already discussed. what is the dose you are going to prescribe, which is the route, whether it is an IV or like oral, and how long we have to give. So whenever you are like initiating an antibiotic, we should have idea about all those things, like the which antibiotic, what is the dose, what is the route, and how long we are going to give the antibiotic. So the drug of choice or the antibiotic of choice depends on the many situations in a patient. Like first of all, the severity. Like here, now we have already told the patient is having tachycardia and hypotension, or the patient is in the septic shock. So the basically whether the patient is a stable outpatient or like a stable patient or a critically ill patient. So that is very important in deciding the antibiotic. And again, you have to decide about the timing, route, spectrum, etc. Depending on the severity also. So here, as I've already told, the patient is having a very severe infection, and patient is already having a septic shock. Second thing, the source is too important. Like here, we are having a patient with a urosepsis. So whatever antibiotic you are going to choose, that antibiotic should have a maximum concentration in the source which we are going to treat. Suppose if you are going to treat a like urinary tract infection or like a urosepsis, the antibiotic which you are going to use should have a good concentration in the urine or in the urinary tract. Same way, if you are going to treat a biliary sepsis or like an osteomyelitis, etc., you should have an antibiotic which is having a maximum concentration. Say, like for example, like if even if you are having a aminoglycoside sensitive organism which is causing a hospital-acquired pneumonia, you cannot use the aminoglycoside as a single agent because the concentration of this drug in the epithelial lining fluid is minimal. You cannot use that. So the source of infection and the drug what you are going to use is very, very important. Without knowing the source, you may not be able to choose a proper antibiotic. Like if you're having a CNS infection, the antibiotic what you're going to use should have a proper penetration to the blood-brain barrier, and it should have an adequate concentration in the CSF. Then next thing should be the like as I've already told, the drug resistant, which we will come to that later. So as far as the tissue concentrations are concerned, like if you are having like an infection related to the lung, we have to see the adequate concentration in the epithelial lining fluid, which I've already told. For example, like lipophilic drugs will be having epithelial lining fluid to plasma exposure ratio at least 1.63. So lipophilic drugs are preferred. Hydrophilic drugs will be having lower concentration, may need higher dose or an extended infusions or sometimes nebulizations. Again, the nebulization part bit controversial, but always remember we have to go for a higher dose or an extended infusions if you are going for a hydrophilic drugs. So we'll come to that later. What is lipophilic, hydrophilic, etc. The bone infection, if you are going to treat, we have to use a drug with a good concentration, or which is the drug concentration should be equivalent to the serum concentration. The examples are like rifampicin, the quinolones, fosfomycin, metronidazole, clindamycin, cefoperazole, etc. The poor concentration like vancomycin, beta-lactams, etc. So if you're going to treat a severe bone infection, you cannot treat it with vancomycin or beta-lactams, etc. The same way, CSF. Like the lipophilic drugs cross easily, like rifampicin, quinolones, etc. But hydrophilic drugs, in the presence of an inflamed meninges, the like dexamethasone may the inflamed meninges can have a better penetration, but the dexamethasone, like in meningitis, if you use it, can again decrease the penetration as it is decreasing the inflammatory changes. Okay, so depending on the source of infection, and again to consider other parameters like lipophilic, hydrophilic, etc., we will have to decide which antibiotic is having a better concentration at that site. Same way, CSF, I've already told, poor penetration even in the presence of inflamed meninges for drugs like aminoglycoside, which we cannot use for a CSF infection. Now coming to the drug resistance. So depending on the resistance pattern, that again how we will decide whether the patient had a previous antibiotic exposure, the previous resistant organism, etc. We know what is the resistant pattern, And depending on that, we will have to decide whether the patient is having an ESBL organism or like a carbapenem producing organism or a carbapenem resistant organisms. Then decide, depending on that, we will have to decide an antibiotic. So the local cumulative susceptibility data in your institute is also important as far as the drug resistance is concerned. Now coming to the patient factors, you have to think about the allergies, whether the patient had any previous drug allergies. What about the renal and liver function? If the patient is having a renal impairment, obviously we'll have to modify the antibiotic. Again, if the patient is having a severe liver dysfunction, some antibiotics you may not be able to use that. So that factors also should be considered. Then the pharmacokinetic is also important. Like suppose if the patient is having an increased volume of distribution, then the like in third spacing, hypoalbuminemia, acute kidney injury, ECMO, RRT, etc. There will be increased volume of distribution and hydrophilic antibiotics like aminoglycosides, beta-lactam antibiotics, colistin, glycopeptides, especially vancomycin, teicoplanin, then lipopeptides, daptomycin, etc. These are the hydrophilic antibiotics, and these hydrophilic antibiotics will be having increased volume of distribution, and we will have to increase the dose in such cases. And increased loading dose and maintenance dose may be decreased, may be used. And lipophilic antibiotics like fluoroquinolones, the clindamycin, tigecycline, doxycycline, minocycline, macrolides, etc. Again, there is no impact on dosages during these situations, but ECMO may decrease the levels in that situations. Now coming to the host factor to the hypoalbuminemia, again highly protein-bound antibiotics like beta-lactams, teicoplanin, daptomycin, tigecycline, clindamycin, erythromycin, etc., can increase the free drug protein-bound drugs. And again, we'll have to balance it with the increased volume of distribution and the increased augmented renal clearance. So there are highly protein-bound drugs, and there is no not protein bound like fluoroquinolones, vancomycin, oxazolinones, polymyxins, aminoglycosides, etc., where hypoalbuminemia may not do anything on the drug levels, but the protein-bound antibiotics definitely we have to be careful. Now coming to the cultures. So ideally, blood cultures prior to the starting antibiotic we will have to use, but the 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 normal or the present automated cultures what we are using, that is having an antibiotic neutralizing agent also in the culture bottles. So that may be immaterial, but ideally if we can do a blood culture before starting antimicrobials, that is better. But if the antimicrobial usage or like antibiotic initiation is getting delayed, definitely you should not delay the taking blood cultures also. And again, you have to always think like even if you're getting a positive culture, it can be because of a contaminated culture, or in case of a urine, it can be because of an asymptomatic bacteriuria, or sometimes it can be because of a urinary tract infection as well. So whenever you get a positive culture, you should have a clinical assessment, which I've already told initially. And based on the clinical assessment, you have to decide whether this can be a contaminated culture, or like in case of a urinary tract infection, whether it is asymptomatic or the patient is having a symptomatic UTI. So once the antimicrobial is started, during the subsequent evaluation, as I've already told, we have to do the clinical reassessment, data review, and based on that, we will have to modify the antibiotics. So what are the re-evaluation part we have to consider, especially when we choose an optimal antibiotics? We have to review the microbiologic data. We have to assess the spectrum of antibiotics what we have used. We have to check for the adverse effects and evaluate the route and duration of therapy based on the infection what we are going to treat. So see here we have a like organism which is like E. coli, and we are getting a sensitivity report. So whenever we get an organism like this, and again like a sensitivity report like that, how we are going to interpret the data? The first thing we have to see, like whenever we are getting an E. coli, you look at the beta-lactam. Usually we treat with ceftriaxone or cefotaxime. See, the ceftriaxone is sensitive here. That means there is no ESBL here. So in that case, we can use with a ceftriaxone itself. Suppose if ceftriaxone or the ceftriaxone is resistant, especially in gram-negative organisms like E. coli, that means there is an ESBL producing E. coli. In that case, we have to look at the BL-BLI combination, beta-lactamase inhibitor combination like a piperacillin tazobactam or a cefoperazone sulbactam, see whether it is sensitive or not. If that is also resistant, then look at the carbapenems and drugs like tigecycline to decide like what antibiotic to be started. So that is how we approach a culture and sensitivity report. So does the microbiologic data make sense? That is very, very important whenever we get a microbiologic data. So we have to definitely review the microbiologic data. So here the urine culture is growing E. coli. So definitely that makes sense because E. coli is usually seen in urine cultures. So we have to see what is the spectrum. So the isolate was susceptible to all antibiotics, and as I've already told, it is susceptible to ceftriaxone also. And ceftriaxone is having enough concentration in the urinary tract as well. The patient is already hypotensive. We have started initially like we cannot take chance and start like a ceftriaxone for a hypotensive or a septic shock patient. We will have to start either like a piperacillin tazobactam or carbapenem. I'm not going into the controversies like whether to start a carbapenem or BLBLI combination, but definitely we'll have to go for either a BLBLI or in most of the cases carbapenem, which again we will discuss in the further session whether to go for a carbapenem or BLBLI. So here the isolate is susceptible to all antibiotic, and again we can decide based on that. Then next, once the spectrum is known, whether to go for intravenous versus oral. This is the again one area where the concepts are changing. The previously the dictum was whenever we have a severe infection, we have to always treat it with an IV. Even the infective endocarditis should be treated with an IV drugs alone. But now again the data are evolving. Even an IE should can be treated with a oral antibiotic, maybe in the especially the continuation phase at least. So those things also should be considered. Then you have to always look at adverse effects, whether the renal function is normal or not. If there is a renal function impairment, how to modify the dose based on the creatinine clearance. So based on the Cockcroft and Gold formula, you can see what is the creatinine clearance depending on the age, body weight, etc. Then decide whether to modify the dose or not. Then what are the principles of antimicrobial prescribing? So it is mind me here like microbiology guides therapy wherever possible. Indication should be evidence based, as I've already told. Narrowest spectrum should be required. So whenever we have a culture and sensitivity, always choose a narrowest spectrum antibiotic and dosage appropriate to the site and type of infection. So even if you are using the same drug, the dose may be different for different site. Like if you are using a ceftriaxone, a 1 gram IV or a 2 gram IV OD will be enough. But if you are using like a CNS infection, we will have to use for 2 gram twice daily. The duration of therapy, try to use for the minimum therapy. There is nothing like the course of antibiotic. The previously we all worked out like a minimum course of 5 to 7 days for any antibiotic should be used once we initiate it. Otherwise, the patient will become resistant to that antibiotic, especially when we use that antibiotic again in the later point of time. That concept is also questioned nowadays. So whenever the patient responds, so you will have to continue for another 24 to 48 hours, not more than that. Even a bloodstream infection can be treated with 5 to 7 days course of antibiotic. And ensure monotherapy in most cases. again, a bit controversial area, like in neutropenic patients and all, whether to use a monotherapy or like a combination, especially when we suspect pseudomonas, etc. That we will discuss in bit later. But always keep in mind, if you have a sensitive organism, we don't have to use for a like a dual antibiotic even for a pseudomonas infection. Uh, so the case here in the case, another case again we are going with the clinical assessment, etc. So here, like a patient is having a positive urine culture 3 weeks ago. The urine culture performed because of dysuria, urinary frequency. Now the patient is asymptomatic, normal physical examination. So this is a 46-year-old lady who had a positive urine culture 3 weeks ago. Now she is coming with dysuria, urinary. That time the urine culture was performed because of dysuria and urinary frequency, but now she is completely asymptomatic and a normal physical examination. So, or in other words, coming with an asymptomatic bacteriuria. So, should she submit another sample for urine culture? So obtain urine culture only when you clinically suspect a UTI. If the patient is not having like dysuria, increased frequency, fever, etc., you don't have to do a culture at all. And a contaminated urine cultures and asymptomatic bacteria are very common. So you should always think about this contaminated urine culture and asymptomatic bacteria. So you don't have to treat all positive cultures at all. So how we are going to interpret the urine analysis? We have to look at the how much whether there is a protein, then again the pus cells, etc. And the absence of pyuria provides reassurance against a UTI, and high number of squamous epithelial cells suggests specimen contamination. And again, always think that if there is no numerous pus cells and say some 20 to 30 in high power field doesn't mean that the patient is having a UTI. Usually, the patient should have a numerous pulses in a urine high power field examination. Like a few numbers doesn't mean that the patient is having a urinary tract infection. But at that point of time also you have to see the clinical assessment whether the clinically the patient is having the features suggestive of a urinary tract infection or not. So what is asymptomatic bacteriuria and what are the limited indications for asymptomatic bacteriuria treatment? Like you get a numerous pustules in urine, patient is completely asymptomatic. What are the situations where you have to treat the patient? If the patient is pregnant, definitely we have to treat. Again, if there is an invasive urologic procedure you are planning, you will have to treat. Otherwise, you don't have to treat asymptomatic bacteria at all. The test of cure culture should not be performed. Like you have initiated an antibiotic for a patient with dysuria, numerous pustules. Again, after that, the patient has become completely febrile. There is no increased urinary frequency or no irritative voiding symptoms. So you don't have to repeat a next culture and confirm that the urine is completely sterile. So depending on the symptoms itself, you can decide whether to stop antibiotic or uh, whether to stop antibiotic or not. So how we will decide whether the patient should be submit for another culture? So here it is not required because she is asymptomatic. That's why there is no indication for culture. And again, you will have to definitely educate the patient also, like why we are not treating even though the patient is having numerous pulses in the urine. So here a 45-year-old lady presenting with dysuria, increased frequency. She denies vaginal discharge. She's having a fever. The physical examination is normal. She has already received trimethoprim sulfamethoxazole, the cotrimoxazole, 2 months ago. So how we are going to decide the antibiotic here? Depending on the severity, it is not severe, then it's a stable patient. Like as far as the source is concerned, it's a urinary tract infection. Most common pathogen, as we have discussed, is E. coli. The drug resistance, because there is a recent antimicrobial usage. So it's possible that as we have used cotrimoxazole recently, she may be having a like resistant organism. So we will have to select antibiotic accordingly. The patient factors are also important. So, like if the patient is having a urinary tract infection, what antibiotic we are going to use for an uncomplicated cystitis? Always keep in mind, I'm not talking about a situation in an ICU. This is just to learn the basic concept about the antibiotic prescribing. So, whatever we are discussing right now is not for a sick patient in the ICU. So, if the patient is having only cystitis without the complications which you already mentioned, we can go with a nitrofurantoin 100 milligram twice daily, or like a quatramaxisol 160 800 twice daily. Phosphomycin, the sachet, we can go with a single dose or like 3 days, or other antibiotic can also be used. What are the patient factors to be considered? Like I've already told, whether the patient is having allergies, whether the patient is having a renal or liver dysfunction, if the patient is pregnant or not. Because if the patient is pregnant, definitely we will have to treat asymptomatic bacteriuria also. This increased volume of distribution, all those things which we have already discussed, and the cultures. Obviously, we will have to do the urine cultures also. And depending on like the drug resistance, we will have to discuss about other antibiotics also. So the sepsis will be having microcirculatory, macrocirculatory dysfunction, and you can get a positive or a negative culture. And if you should always aware that there is an entity called culture negative sepsis. And if it is a sepsis, you have to always think, is it bacterial itself or it is a sepsis mimic, etc. So those point also should be considered. And whenever we take a blood cultures, as you all know, one set means one aerobic and one anaerobic culture. And one set will usually yield around 73% of positivity, which you can increase up to 94% with two sets, and almost 97% with three sets. So, because of the cost issues, etc., majority of the unit we go with two cultures. Where we can expect, or where we can increase the sensitivity up to 93 percentage. But like as you can see here, the three sets are ideal. But as I've already told, because of the cost issues, we will have to restrict that. The antibiotic, the prescription, etc., which we have already decided. Then what the route we are going to use that? Again, whether the patient is stable, whether the patient is eating properly, whether he can absorb. If the patient can absorb, oral option is possible or not, which we will have to think always. So this is the bioavailability chart of different antibiotic what we are using. You can see the antibiotic like cotrimoxazole, doxycycline, clindamycin, amoxicillin, rifampicin, linezolid, etc. are having an excellent oral bioavailability. So if the patient is tolerating orally, you can use either of these antibiotic. Obviously, we'll have to consider the severity of infection, etc. But if you want to use a prolonged antibiotic, we can use these drugs. Here again, this IV doxycycline is the one drug which we are like misusing nowadays. Even if you are treating a rickettsial infection, if the patient oral absorption is good enough, like as you can see, the doxycycline is having an excellent oral bioavailability. Oral doxycycline is like as good as IV doxycycline in that situation. But obviously, as I've already told, if the patient is having a GI intolerance, definitely we will have to think about an IV or like a parental preparation. Then regarding the pharmacokinetic pharmacodynamics, there are two types of drug, like a concentration dependent antibiotic and a time dependent antibiotic. So here you can see the concentration dependent antibiotic. The killing depends on the time above, sorry, the concentration above MIC. So if we can attain a maximum concentration above the MIC, you will be having a better killing. So in that case, you have to use a bolus drug like what we are using for an aminoglycoside, etc. And once the maximum drug concentration is achieved, you will be having a better the killing effect. Whereas the drug which is having a the time dependent antibiotic, you have to see the antibiotic is having maximum time above the MIC, and here the optimal use is with the optimal duration of exposure. So how can we like obtain an optimal duration of exposure? Like here we can go for an extended duration of infusion. Like if you are going for a piperacillin tazobactam, you can go with 4 hours infusion. A meropenem can be infused over 3 hours, like imipenem can be infused over 2 hours, etc. So for a beta-lactam antibiotics, with the time-dependent killing effect, always go for an extended infusion, especially when we are treating like sick patients in the ICU, and we have enough evidence for that. I'm not going to discuss the literature, etc. today. So if you are going to treat with an antibiotic with a which is having concentration dependent, we have to go for a maximum concentration. But if you are treating with a beta lactam like antibiotic, the time above MIC is very important, and we have to go for a extended infusion time above MIC. And again, we have to always think about the antimicrobial resistance and therapeutic options whenever we initiate an antibiotic. So the antibiotic what we are going to give can increase antimicrobial resistance in the patient. At the same time, once you have an antimicrobial resistance, your therapeutic options are also getting narrowed. So this is a very, very important slide. And I think you all will be knowing the basic concept about this one. Like as you can see, 1 minute, I'll just connect the power. Okay, sorry. So here, see, here we are going to we are going to initiate an antibiotic here. So see, this is a population of susceptible bacteria, and we are initiating an antibiotic here. So the situation what you can think is like we are getting a VIP patient or a VVIP patient with trauma. So on the first day itself, we are initiating meropenem, thinking that the patient should not get any infection. So see these yellow dots, and all the organisms are susceptible to meropenem. But keep in mind, at least one or two may be there which is resistant to meropenem. So what is going to happen now? So here, once we initiate the antibiotic, it is going to stop all the susceptible organism. But at the same time, what is going to happen? The resistant organisms will select out. So you can see the organism which is resistant to meropenem. Here we are initiating the meropenem. It is killing all susceptible organism. But see, the organism resistant to meropenem is building up, and finally we will get a population of resistant bacteria. So even if you initiate an antibiotic like a meropenem on the day one itself to treat a community acquired pneumonia, which is not required initially. So finally, by the end of third or fourth day, you will be ending up with the group of bacteria which is resistant to meropenem also. So this is the basic concept about the antibiotic use. That is why we have to use a narrow spectrum antibiotic in the initial days. Even if you go with a carbapenem or like a carbapenem colistin combination initially itself, you are not going to prevent further infections. Now coming to the organism, the basic concept about the organisms. We have the gram-positive bugs, we have the gram-negative bugs, and we have the anaerobic organisms, and we have atypical organisms also. So what are and we have obviously we will be having the intracellular organisms. The gram positives are streptococci, we have staphylococci, like methicillin sensitive, resistant, and coagulase negative, what we call as cons, and enterococci. These are the common gram-positive organisms. The gram-negative can be non-fermenters like Acinetobacter, Stenotropha modus, Pseudomonas, and Burkholderia. So the non-fermenter category includes Acinetobacter, Stenotropha modus, Pseudomonas, and Burkholderia. And the gram-negative, the other group is Enterobacteriaceae, where we have the E. coli, the Klebsiella, the Salmonella, Proteus, etc. Okay, so we have an Enterobacteriaceae and non-fermenters there. And in the atypical, we have Legionella, Mycoplasma, Chlamydia, etc. Like in atypical pneumonia. So whenever we initiate an antibiotic, the antibiotic should cover these atypical organisms. And we have the intracellular organisms like Rickettsia, then again Coxiella, Salmonella. Salmonella is having again an intracellular, even though it is an Enterobacteriaceae. Then we have the anaerobic organisms. Again, we have gram-positive, gram-negative, and we have the Clostridium difficile also in the anaerobic group. So now, with this basic knowledge about gram-positive, gram-negative, atypical, and anaerobes, we will go with each antibiotic class. So the first one is beta-lactam antibiotic. So what are the beta-lactam antibiotics? Penicillin, cephalosporins, carbapenems, and monobactams. So in the penicillin, we have again the natural penicillin like penicillin G, or we call it as a crystalline penicillin. Oral, we have the penicillin V. Then anti-staphylococcal penicillin like cloxacillin, procloxacillin, nafcillin, etc. The oral form will be cloxacillin or dicloxacillin. Though the plain cloxacillin is a bit difficult to get nowadays, but flucloxacillin, even though it is a bit expensive, it is available. Then aminopenicillin like ampicillin, amoxicillin, etc. Then beta-lactamase inhibitor combination, BLBLI, ampicillin sulbactam, amoxicillin sulbactam, or moxclav. So you can either go for a ampicillin sulbactam, amox sulbactam, or like amoxicillin clavulate. This amox sulbactam and amox clavulate combinations are easily available. Then we have oral amox clav combination. Then extended spectrum penicillin like piperacillin, tazobactam. Then extended spectrum penicillin with the beta-lactamase inhibitor like piperacillin, tazobactam, and ticarcillin clavulate. Especially when you have when you need a pseudomonas coverage, you will have to go for that. So this is about the penicillin. So what about the sensitivity of the penicillin? Again, as I've already told, the penicillin, we have the gram-positive organism. You can see like the MSSA, Streptococcus, etc. Flucloxacillin is having a excellent sensitivity, but amoxicillin, the staph sensitivity may not be that good. Piperacillin, tazobactam also, it is not preferred for MSSA. The flucloxacillin will be a better option. Coagulase negative staph also, you can use clogs, etc. Mox may not be a good option. But the gram-negative organism, if you are going with E. coli, etc., amoxicillin, amoxiclav, etc., can be used. But again, if you want an extended spectrum, like in Acinetobacter, Stenotrophomonas, like the non-fermenters, we will have to go with the piperacillin, tazobactam. And here you can see the atypical organisms. It is not having any effect. And Rickettsia Klebsiella also, the penicillin is not having any coverage. So this is the basic concept, and this you should always know, like whenever we initiate an antibiotic, like which organism you are going to treat, and what is the spectrum of the antibiotic what we are going to use. Like if you want to learn it in detail, like it is given nicely in the Sanford guide. I just made an animation from the Sanford guide. So if you go to the Sanford guide, all these things are beautifully given. So what is another important thing which we can learn from here? Like see the penicillin, amoxicillin, piperacillin, tazobactam, etc. is having an excellent anaerobic coverage also. So what is the inference? So if the patient is already on a piperacillin, tazobactam, you don't have to add metronidazole or clindamycin to get an additional anaerobic coverage, because the drug like amoxiclav or piptazo or like amoxicillin or your crystalline penicillin, all these are having an excellent anaerobic coverage. So you don't have to like use metronidazole or clindamycin in that situation. And again, there are the literatures coming up, especially the anti-anaerobic antimicrobial will increase the risk or complications, especially when we use in critically ill patients, which we will discuss in the subsequent sessions. So again, the gram positive I've already told, like the penicillins, the daptomycin, the natural penicillin, tetracycline, clindamycin, quinolones, etc., are having a good spectrum against gram positive. But as far as the gram negative is concerned, we have to go for extended spectrum penicillin with beta lactamase inhibitors like piptazole or ticarcillin flavulate, or third, fourth, or fifth generation cephalosporins, carbapenems, monobactams, aminoglycoside, colistins, quinolones, etc. And the modest activities with the extended spectrum penicillin, macrolides, tetracyclines, sulfa drugs, etc. The atypical organisms are concerned, the quinolones, tetracyclines, and macrolides. These are the three groups of drugs which can be used for covering atypical organisms. As far as anaerobic organisms are concerned, I've already told the aminopenicillin beta lactamase inhibitors like mosclav, piptazole, ticarcillin flavulate, etc., are having an excellent anaerobic activity. Same way, carbapenems, uh, uh, the extended spectrum beta penicillin beta lactamase inhibitors like piptazole, ticarcillin flavulate, etc., are also having like anaerobic activity. It is true that metronidazole, clindamycin is also having, but you may not require that. And penicillin, aminopenicillin, vancomycin, tetracycline, clindamycin, linezolid, etc., are also having good anaerobic coverage. So now coming to the penicillin and the spectrum, see the different penicillin like oral penicillin, crystalline penicillin, the cloxacillin, then other amoxicillin, etc. You can see this is with the good sensitivity, like strep pneumonia and strep pyogens. All these antibiotics are sensitive, but the crystalline penicillin is having an excellent sensitivity. As far as the virulent streptococci are considered, the activity is moderate. But if it is a methicillin sensitive staph, as you can see, the flucloxacillin and cloxacillin are having excellent sensitivity. Others can be used, but the sensitivity is not that good. But if it is an MRSA, none of these penicillins are sensitive. Then coagulase negative staph, cons also, again, the sensitivity pattern will be same for the other penicillin like clogs or flu clogs. But if it is a coagulase negative staph, which is methicillin resistant, again, you may not be able to use any of these things. So the MR counts, we will not be able to use these antibiotics. So this is the spectrum as far as the penicillins are concerned. So as far as like if you go for anaerobic organism, which I've already told, these drugs are having an excellent sensitivity. Then the anaerobic gram positive, again you can see a good sensitivity with amoxicillin, clavulic acid, etc., which we have discussed. As far as the gram negative organisms are concerned, like E. coli, you can see ampicillin, sulbactam, piperacillin, tazobactam, etc., are having sensitivity, but piptazo is having a better sensitivity, but all other antibiotics are not having sensitivity. Same way, the H influenza, leptospirosis, etc., you can use all these, and leptospira, you can see it is sensitive to all these penicillin. And this is the one thing you have to always keep in mind. Leptospira is almost sensitive to all antibiotic like ceftriaxone, crystalline penicillin, piperacillin, meropenem, etc. So if the patient is already on ceftriaxone, piperacillin, tazobactam, etc., you don't have to add crystalline penicillin to increase the activity against leptospira, because all these antibiotics will cover leptospira in a very good manner. And again, there are studies comparing crystalline penicillin with ceftriaxone in leptospira, and again, some studies are showing excellent activity with ceftriaxone. So if it is a leptospira, don't think that you have to always start crystalline penicillin in those situations. The cephalosporins, again, we have different generations, like first generation, second generation, third generation, fourth generation, etc. I'm not going into the details because it's already 50 minutes over. But always keep understand this thing. The first generation cephalosporin like cephalosporin is having the good staphylococcal activity, but not active against MRSA. It is also active against gram-positive anaerobics, but third generation is having a better the activity. MSSA also, this is the activity. As far as the strep is concerned, first, second, and third generation is effective. That is why you can use strep, you can use ceftriaxone to treat streptococcal infections also. Cefuroxime is also having activity against MSSA, but again, the cephalosporin is the preferred agent. But the gram-negative, the sensitivity is minimal, and again, there is no coverage for atypical organisms. So this is the about cephalosporin, cefuroxime, cefotaxime, etc. Non-ESBL we can cover. Other than that, this is the coverage. See, the metronidazole is having an excellent anaerobic coverage, but these drugs are the second generation, third generation cephalosporin, etc. The anaerobic coverage is not that good. So obviously, we will have to add clindamycin or metronidazole to increase the anaerobic coverages. So these are the other cephalosporins and the sensitivity against the gram-negative organisms. You can see the E. coli, it is almost sensitive, but the oral beta cephalosporins may not be that effective. I'm not going to the full details about these spectra because it will take again more time. And as far as the atypical organisms are concerned, I've already told azithromycin, levofloxacin, and doxycycline whenever we suspect atypical organisms. So to conclude, so what are the points we should learn? All antibiotics have a potential harm. Don't think that antibiotics are not having any harm and we can use antibiotic without indication. Not like that. Taking antibiotics can increase the resistance and can cause many other problems. And intravenous is always better than oral. Like in paracetamol, you always we think that IV paracetamol is better. No, it is not true. Oral paracetamol is also having an excellent oral bioavailability. So you don't have to use IV paracetamol if the oral the oral absorption or the GI tolerance is good. The same way, oral antibiotic can be just as effective as IV. We can even treat an infective endocarditis with oral antibiotic. And the broader spectrum means more powerful, and once it is initiated, we have to always continue with that. Nothing like that. De-escalation should be always considered depending on the culture and sensitivity. And antibiotics are needed to prevent infection in all procedures. No, antibiotic prophylaxis is not required for all surgeries. And even if we use antibiotic for surgical prophylaxis, it is for limited time. You should get a maximum concentration during the incision time only. A surgical antibiotic prophylaxis is rarely needed beyond 24 hours. I'm not going to discuss in detail what are the indications where we have to increase or repeat the dose, there is a huge blood loss, the duration of surgery is delayed, or the initiation of the surgery is delayed, etc. We may require a second dose, which we can discuss in later classes. Antibiotic prophylaxis is not required for catheter or drain. Like if the patient is having an ICD or a Foley's catheter, etc., doesn't mean that the patient should be on a catheter or on an antibiotic. And antibiotic resistance usually happens because of bacteria change. It is not because of an antibiotic change. Everyone can help to reduce antibiotic resistance. So everyone, including a critical care physician, is having a role. And don't save antibiotic for another time. Whenever it is required, you use it appropriately. So thank you so much, and really sorry for taking more time than allotted. I was trying to give you an overview about the basic concept about antibiotic usages, and again some basic clinical situations. Maybe with these basic things, in the coming sessions, we will see the antibiotic spectrum of the higher antibiotic, and depending on the common infections like a community acquired pneumonia, skin and soft tissue infection, biliary sepsis, abdominal sepsis, etc., osteomyelitis, infective endocarditis. So the common situations And again, the organisms like Acinetobacter, Klebsiella, Streptococcus, Pseudomonas, etc. The organism-wise, which antibiotic to be selected, and the source-wise, which we have already discussed, which antibiotic can be selected. And obviously, nowadays, whenever we get a multi-drug resistant organism, which antibiotic will be ideal based on the recent available evidence. How to interpret a cultural sensitivity report? What is the difference between like a genomic sensitivity and a phenotypic sensitivity? If you have a result based on biofire or any other advanced AMR panels based on the AMR the panel PCR panel, how to select the antibiotic, etc. We will discuss in the coming sessions. Thank you so much, and really sorry for taking more time.
No, no. Thank you, Dr. Anup. It was wonderful delivery, and it was such a lovely insight to such a vast topic. And you have almost covered all the antibiotics and the problems related to it. Okay, I mean, there are challenges pertaining to the use of antibiotics. Sometimes we get confused as to how do we go about starting antibiotics, like whether we should go ahead with the monotherapy or combination therapy. There are several papers. There is a lot of debate about duration of antibiotics, and antibiotic misuse is also one of the problem, and for that we need an antibiotic stewardship program. So that itself is a different topic to be discussed. We will discuss it later. So today, you have discussed most of the topics. There are a few questions in the chat box. Would you like to take these questions? And we have moderators also. Dr. Swapnil is also there, and Dr. Nader is also there. And there are queries pertaining to the anti-tubercular therapy. A lot of times
I think
we feel
ATT we will discuss in detail in the coming sessions, depending when the patient developed drug-induced liver injury, how to proceed, like how to change the drug, and what are the like drug-resistant TB, how we are going to discuss, etc. As we have not discussed in this class, that part we will quit now. And what oral step-down therapy can be given for MRSA organisms? Obviously, there are
yeah.
antibiotic which is effective against MRSA, like linezolid is having an excellent oral bioavailability. Doxycycline can also be used. Rifampicin, there are selected situations, but don't think that the MRSA bacteremia can be treated with these oral antibiotics, because depending on the site of infection, we may have to get a proper drug concentration. So, if it is having a MRSA bacteremia, we may not be able to use an oral antibiotic in that case. Uh, Next question.
Yes.
How should we choose
But it is also
antibiotics?
very important that it is not just the antibiotic that we keep on choosing and shuffling one after the other, but the source control is also very very important. I hope you
Yeah, that is
agree,
a very, very
Dr. Anup.
valid point. The source control is also very, very important. And once we have a proper source control, the duration of antibiotic can also be reduced. As far as the soft tissue, the antibiotic, the usage for skin and soft tissue infection, again, you have to think about an antibiotic with an excellent tissue penetration. Like linezolid, as I've already told, is having an excellent penetration. The same way, like whenever we having a suspect the PVL toxin production, etc., we have to initiate an antibiotic which can prevent the toxin production, like clindamycin, linezolid, rifampicin, tigecycline, etc. This protein synthesis inhibitors can be used for the PVL toxin inhibition also. Other than that, we can go with other any beta-lactam antibiotics, or like if the resistance you suspect because of a immunocompromised status, diabetic, previous antibiotic exposure, etc. BL-BLI combination is also effective.
Even new
So,
oral
Dr.
antibiotics are also available, like levonaglifloxacin is also available, which is an excellent penetration for skin soft tissue infections, and especially for patients with the biofilm related infections, having devices and with the biofilm. Levonaglifloxacin is also one of the options, though it also has some gram negative coverage also, but it is excellent anti-MRSA antibacterial agent. That is the case.
So, Dr. Anup, so basically, I can say in a very short and sweet manner that the more we use, the more we lose actually. So this should be the dictum of every antibiotic policy. So it should has to be used judiciously and in a proper way. And looking at the antibiogram and always we have to restrict most of the antibiotics. It should not be used in left or right in any scenario. So that is the reason this antibiotic stewardship is very important in a hospital. So yeah, so of course that we are going to
And
take in the
antibiotic
second
therapy
lecture.
should also be guided. Yeah, it should be guided by several biomarkers. You have procalcitonin, you have clinical profile, which is whether improving or deteriorating, and the response to the treatment also will help you to guide further continuation of antibiotics, selection of antibiotics, duration of antibiotics. And yes, it is very important to understand the PKPD profile, as Dr. Anup has already highlighted. That is one of the essential part of the antibiotic administration and choice of antibiotics. So,
One more last
any other
question from
question?
Dr. Vishnu Raj. He was asking about oral bioavailability in shock patients already on vasopressors. No, like if the patient is already in shock, we cannot try oral antibiotics in that patient. Definitely, we will have to start the patient on IV antibiotics itself. Like whenever we talk about the switch down to oral antibiotic, it is for a stable patient alone. As you have correctly mentioned, the patient who is already hypotensive with compromised blood circulation to the gut mucosa, we cannot predict on oral bioavailability in such cases.
Yeah, that's absolutely right. Oral absorption will be compromised, especially when the patients are on very high doses of vasopressors. So, and not only the PKPD, but also we should be able to understand the resistance pattern also, which itself is another topic to be discussed. So, all these parameters, resistance pattern, PKPD, and the bioavailability, and the route and the penetration of the antibiotic is also one of the selection criteria for this. Yes, there is one question. I mean, this lecture will be available on YouTube for the viewers. Once the lecture is over, we will send it for editing, and it will be available on YouTube channel. So, if there are no further questions, in the interest of time, can we conclude the session?
Yeah,
Dr. Anup, it
thank
was indeed great pleasure. It was indeed a really great pleasure to have you with us, and would like to hear from you again and again. Quite interesting topics like antibiotics and resistance pattern can also be discussed later. And
and
if you have any
the
questions,
mechanical
these
ventilation,
questions can
NIV,
be.
HFNC, those sessions
Yes.
also we'll discuss in the subsequent sessions.
Oh, yes, definitely. We will have series of lectures, and we will have, Dr. Anup and the panelists from the member of Apollo team will definitely help you all to discuss certain important topics. But I think we can conclude today. Again, on behalf of Apollo Critical Care Learning Network, I would like to thank you again, Doctor. Hope to see you again. And good night for now. Thank you very much. Thanks a lot.
Good night. Good night. Thank you. Thank you so much.
Sir, there is someone have asked about the next topic. Hello, sir. Akhilesh, sir. Someone has asked next topic.
So the next topic is we'll have to share this.
So this is basically the next topic. We are going to now the different basic topics for all the critical care exam goers, keeping in mind the future exam goers. So we will start with the basic topic like arterial blood gas analysis. So just stay tuned to our program Thursday 7 o'clock, 7 o'clock every day, every week. I mean to say, and we are uploading our videos also in the YouTube channels. So subscribe to it slowly and be touch with us. So the next class will be on ABG analysis.
Yeah. So see you next time, next Thursday. Bye bye for now. Thank you very much.
Yes.
Good night.
Thank you, sir. Thank you very much, sir. Thanks, sir.